Thank you for tuning in to Promising Me Unleashed. We have with us our guest, Dr. Cynthia Major Lewis. She is a board-certified psychiatrist and the director of adult psychiatric emergency services at Johns Hopkins Hospital. Dr. Lewis, thank you so much for joining us on Promising Me Unleashed.
Thank you for having me.
I am so glad that you are here to talk with us just a little bit about what's happening in the world of mental health and the impact that it's actually having on our world and society today. Before we get started, we'd like you to just share just a little bit about yourself, your background, why mental health. All those things are going to be important for those who are viewing today.
Okay, well, again, thank you for having me. I do need to say that although I do work for Johns Hopkins, my views today are my own and don't represent my employer. But that they are aware of my kind of activism and my passion for mental health in the community. So I do need to state that first. But again, my name is Cynthia Lewis. I am a psychiatrist, a board certified psychiatrist. I grew up in Nashville, Tennessee, and I have a twin sister who, when we were young, we were our own separate selves, even though we were twins. But people would always say, oh, she's going to be the attorney and she's going to be the doctor, because I was always taking a interest in what makes people tick and kind of the more concern for people, where she was very black and white and there is no kind of gray. And that's really what happened. She's an attorney and I'm a psychiatrist, physician. And so that rang true. But I went to Howard University for undergraduate studies. I went to Meharry Medical College for medical school. I did my internship and residency here at Johns Hopkins. And in my senior year, my fourth year, I was named chief resident, was actually the first African-American female chief resident ever here at Hopkins. So I did have a service obligation to the government, where I served 3 years in an underserved area on the Eastern Shore. And that's really what introduced me to more community work and more working more with the more vulnerable and disenfranchised because of my obligation. I then came back to Johns Hopkins and worked in our community psychiatry program for about 15 years. I also started a private practice where I ventured into working with injured workers. But then I was asked to direct our emergency department from 2010 to 2015. And I did it more from afar. I was supervising our residents. I was kind of running cases by them, but I wasn't embedded in the emergency department. In 2019, I was asked to come back and to be embedded in the emergency department, which means all of my clinical work is all in the emergency department. And it was really then that I began to realize that, you know, even though I've been in the community and taking care of very ill people, I often had a good collaboration and a good rapport and good support systems with my patients. But in the emergency department, I started to, see a lot of, repeat visits, a lot of patients who were not doing well. And I started to question, why do we have this population who is really failing, and why are we allowing them to fail? So again, my passion will probably speak further, but I'm now the full-time assistant professor for community psychiatry. Well, for psychiatry, I still have my private practice, very minimal, but again, my passion is in treating patients with severe mental illness. I am a general psychiatrist, but I see that that's where kind of my passions lie. So
Awesome.
2 young daughters here, live in Baltimore. I live in Baltimore. I'm now a transplant, love my city. And I'm happy to be here.
Awesome. It's interesting to hear, your movement right on the cusp of COVID. And I can only imagine the impact that alone had in the increased number of people seeking treatment or seeking assistance in how to cope. And you compound that with what's already, occurring with people as with regards to their mental health. So it's amazing to see, even that transition take place, and how physicians themselves are dealing with this uptick of more patients needing assistance. one of the things that was very interesting, as I read more about you and what you were doing, I know that you had written an article in the Maryland Matters specific to some concerns and a bill that we are trying to get passed in Maryland to address those with severe mental illness. Before we even go there, let's talk about some of, because I learned that there are about 200 types of mental illnesses or mental diagnoses. And I'd imagine from the emergency room perspective, you probably see all ranges from moderate to severe. What does that look like in the emergency room? And how is that managed, within that service?
Yeah, that's a great question. It's interesting because the Bible for psychiatry is the DSM. And when you look at the DSM, it really is it's kind of a guide for people, especially mental health professionals who, when they're seeing a patient and they evaluate a patient, how to then arrive at a diagnosis. And there are tons of diagnoses. At the end of the day, here at Hopkins, we kind of look at formulating patients and we look at the perspectives and we kind of whittle all those different potential diagnoses into certain buckets. And so when you really think about it, there's several main buckets. You have the mood disorders, whether it's depression or bipolar disorder. You have anxiety disorders that are very common, whether it's panic disorder, post-traumatic stress disorder, social anxiety, generalized anxiety. And then you have the psychotic disorders, whether it's schizophrenia, whether it's schizoaffective disorder or bipolar disorder with psychotic features. And then you have more like the eating disorders, what we call somatization disorders. We don't see those as much in the emergency department because those usually don't contribute to emergencies. They're more eating disorders can, but they're usually going straight to eating disorder services or medical services. Right. So it seems overwhelming to people, but when you really think about it, people are coming in with general complaints. Usually they're depressed or even panic, or maybe they're anxious. Or they're psychotic. And when we talk about psychotic, it's when people have kind of, a break from what we call reality. They're perceiving things and experiencing things that aren't really there, whether they're seeing things like visual hallucinations or hearing things, what we call auditory hallucinations that aren't really there, whether believing things that really aren't true, with what we call delusions. So when people come in, they're coming in with specific symptoms, and then it's our job to take a good history to find out what are complicating factors. One, is there a family history? When patients come in with symptoms and we're trying to arrive at a diagnosis, we know that if that person has a mother with schizophrenia or a brother, or, if it's running in their family and they're coming in with symptoms, that they might likely have it as well. We also want to look at, are there recent stressors? Did someone just lose their job? The pandemic, like you said, created a lot of stress. And it's interesting, there were studies that showed that our community, which has usually been more protected from suicide, that in the pandemic, there was thought to be an uptick in just suicides in general, but usually kind of the Caucasian population, which had more suicides in general, they showed a decrease in suicides during the pandemic. And when you look at, but then our communities and communities of color showed a rise in when you think about the essential workers or the ones who were still having to go to work, as opposed to other people who were able to get out of the rat race a little bit, be at home, be with their kids. And that was kind of protective. So we saw a rise in our communities, which was concerning. But all that to say that people, when we take a personal history, we're looking at, was there a recent job loss? Was there a recent loss? We're looking at substance use, which complicates, marijuana, alcohol, cocaine, all of those will exacerbate illness. And then we take a history of what's bringing the person in and what symptoms are having. And what that does is allows us to arrive at a diagnosis. And we like to then, again, put those in buckets. What are the symptoms? What is the family history? And then, how do we formulate them to arrive at a diagnosis and then determine how do we best treat? So you're right. We're here in, I'm here in, urban, East Baltimore, and we do everything, and I think I'm fortunate in that regard, because not only are we seeing, we'll see faculty, students, people descend on Hopkins because they're kind of coming all over looking for answers. But then we also see, in what's going on in our communities, which is a lot of substance use, sadly, a lot of homelessness, patients who are maybe interacting with the police and being incarcerated, and untreated illness that is being allowed to be untreated, and then it affects patients' lives in a negative way, which is why the AOT, the Assisted Outpatient Treatment bill that I've been trying to get passed is so important. So yes, we see again that we see it all, and it allows us to kind of stay sharp in multiple areas. But I think what started concerning me is that, the population who has family, who has a good outpatient team, who has the wherewithal to appreciate that they have an illness and need help, that's great, because there is help out there. There's resources, there's monies out there. I think this thought that there's not enough resources, there really are. The problem is that you've got a population of patients who don't appreciate they have an illness. They've lost their loved ones, they've lost family, they're now kind of homeless, they're circling in and out of the emergency departments and the inpatient units, in and out of the jails, living under bridges. And there's really no mechanism here to help corral them into care, to kind of be the advocate for them, because they're not appreciating themselves. And I've learned a lot, honestly, as I've gotten more involved in this advocacy. And I must say I've been very disappointed by the lack of, I guess the people who are in power, who have the ability to affect change and affect law. I feel like they really don't understand as much, and I think we're getting some traction. But I'm agreeing to be on platforms such as yours, because we really need people to understand that it's going to take a village, and it's going to take voices, and it's going to take common sense to help people to understand that we can't just keep brushing this under, kicking it down the street and thinking that at some point it's just going to correct itself, because there's a lot of work to be done in that arena. So I know I probably
you've actually answered everything specific to this, because I was there at one of the hearings, and just listening to those who were opposed to the involuntary treatment of these patients who are severely dealing with mental illness in a way that has to be managed through some other levels of control. Some of them are not going to voluntarily go for follow-up treatment at the after following an emergency room visit. And I think that's where the breakdown seems to be for those patients. How well can families manage that care outside of some other layer of support? And so, I know, and you can probably speak a little bit more to what we want that bill to do. How do we really want it to function?
Gotcha. No, that's a great question. I will give a little bit of a background. So in our mental health system, we have several layers of treatment. One is outpatient mental health clinics, which are plentiful. They're covered by insurance, where patients who want help get a therapist, they can get a psychiatrist, they can get placed on medications, and it's voluntary. I worked in community psychiatry, a clinic in the community, for 15 years. We have a subset of that population that needs a little bit more guidance and help. So we then will have mobile treatment, or ACT teams, assertive community treatment teams, where they will have people go to their homes. If they can't get to the appointments, they'll go out and give them their medication in the home. They'll work with their families in order to kind of help them stay more engaged and more compliant with their care.
Yes.
We also have in Maryland capitation programs, where patients who aren't doing well, who might need more housing or more wraparound services, these programs are tasked with keeping people out of the hospital, keeping them out of the emergency department, but providing them the resources they need so that they can do well and maintain in the community. Then you have the emergency departments, which are open 24/7. No one's going to be turned away from an emergency department. If you're needing care, if someone else thinks you need care, then you come into the emergency department. And then it's there where we decide, is someone doing well enough where they can be discharged to the community or back home with their family, or they're safe enough for discharge, or do we need to hospitalize them? And then if we need to hospitalize them, then the question is, are you going to come in voluntarily because you recognize that there is a need to get help, or do we do what we call an involuntary certification, which is where we, as in Maryland, involuntary commitment law says that two physicians can say, this person has a mental illness. This illness is not allowing them to appreciate that they're a danger to themselves or others, or can't care for themselves. And so then they're able to come into the hospital, but it's temporary. People come in, they might get back on medicines. If they refuse medications, they'll go before a board, which will say, no, you're so ill, we're going to med panel you and you have to take medicine. Or you do have the right to refuse treatment and you're not severe enough and you're not going to take treatment. And then they'll go before a judge who can determine if they can be discharged or not.
Right.
So that's how we get people who are in acute, an acute illness. The AOT, what the AOT is that there is a subset of patients who cycle in and out of that. But when they're discharged, once they're on meds or not, they get discharged, but they're out there, whether they're homeless or in the community or refusing to adhere to treatment. AOT would provide like a court-ordered kind of mandate to get a community group, whether it's psychiatrist, outpatient mental health clinic, people who are going to help that person recognize that, hey, you do need to take medicine, or you do need to remain in treatment. You're coming to the emergency department, often you're failing, we're concerned that, your outcomes are not going to be what they need to be because you have an untreated mental illness that's impacting. So what assisted outpatient treatment does is allows that court-ordered mandated treatment for that person who has to meet criteria in order to get into a program like that. And what I'm finding is that the opposition is that I kind of liken it to the mask mandates and with COVID. You had a lot of people, a lot of misinformation about taking people's rights away. COVID's not a problem. They just want to make you wear a mask. Whereas we knew that masks really did save lives. We knew that it really did have a purpose, but you had a lot of misinformation out there. And I think that the voices on the opposition side for assisted outpatient treatment are focusing a lot on patients' rights to refuse treatment. Patients should have the right to determine what kind of care they want. And the problem is when we look at patients with severe mental illness and their lack of insight, there's a more anosognosia is another term for it, but it's really someone's lack of appreciation to appreciate that they have an illness that warrants treatment. And it's that population that I'm referring to. And I think when I know that I met you through this movement, that families who are begging their lawmakers, begging the people who are able to pass something like this, that we are not talking about taking people's rights away. We're not talking about the person who had a bad experience and doesn't want to go to this clinic and who are sleeping in their beds at night and okay. We're talking about the person who literally is, their families can no longer care for them. They're failing
on the street.
Deaths. They're being brought in by the police for this just cycle of failure. And if an assisted outpatient treatment bill was passed, then we would have a mechanism for that patient who was failing to say, hey, we're going to give you more supports. And when we find you on not doing well and refusing to take your meds, not because you don't want to, but because you don't appreciate the need, we're going to be that advocate for you to get you back on the right track. And there's a lot of success stories of where Maryland is one of 3 states that doesn't have this. And that's what I didn't know as I was doing my research into this. I knew New York had one because of an unfortunate incident, Kendra's Law, which came out of that. California has one. I thought they were really states that were one of a few that had these kind of laws. And then in my research, I found, no, Maryland's one of 3 that doesn't. And really where finally this year, where I did testify at the House and the Senate, I think it's been at least like 17 years. This is the first year, I believe, that it's gotten out of the House. And I think, I could tell that body of legislators were really interested and I think really want to move this forward, but it failed in the Senate. I think it failed to even kind of get out for a vote. So to me, families who are, have loved ones or who are interested, the more voices that really start rising up to say, this is unacceptable. And let me say this, I've been able to find out the hundreds of thousands to millions of dollars that are being taxpayer dollars that are being used to do this emergency room, inpatient, discharge, this cycle. I saw someone yesterday who would benefit from this program. She was in our emergency department 3 times.
Wow.
And every time she shows up, yes, in one day, that's a visit. That's like an expensive visit.
Very expensive.
One of the arguments was, do we have the cost? Absolutely. When you reallocate, and when instead of spending hundreds of thousands of dollars on someone who's not even doing well, how about we reallocate? And there's tons of folks in that bucket. So if we were to reallocate and really look at how we're spending our monies, let's just spend it more wisely. So,
Right.
I did a talk on it, said the insanity of it all. To me, it's the insanity of, thinking you're going to get a different outcome when you're doing the same thing over and over again. And I just invite people who are at the opposition table to come sit in an emergency department for a week. Come sit in the house of these family members who are having to send their loved ones to other states so that they can get into a program and thrive, and can't even stay in the state that they call home. And so I will tell you that, I think, when I left Hopkins in 2015 to do all private practice, and I pretty much said, I'm good, I'm happy, but I really wasn't happy, because really it was this population that I love to treat. So when I was asked to come back, I really feel like this was my calling, that I am determined until my last breath to get an AOT bill passed in Maryland. And it's, people with like you and others who I think, which is more advocacy and more awareness, that we can start, getting a little bit more successful in that space.
Yes, yes. And you're so right. There is such a need for a coordination of care on this issue specifically. Well, actually, in general, but when we talk about those who are severely affected with mental illness, the coordination of care, and if it has to happen through the court system, that may be the place where it needs to start, where people can really take a closer attention to what's needed for those patients. I do know that people can go to the courthouse and fill out a document to say, my loved one is not doing well. And they will do the due diligence. It does get presented to a judge, and they will make the necessary decision to say, yes, we will go and pick up this individual and get them into care. But what happens after that?
That's a great question.
Where it falls apart.
Absolutely.
And unless you have a connected network already in place to address the needs of those patients, unless by an act of God, they are in an environment where they can get the necessary care that they need, they are back into that same state that you're speaking about, being brought back into the emergency room, and situations where some have been incarcerated. And a lot of people don't understand how to manage a person who is having a psychotic event. The police departments are trying to get on board to understand more and provide training for their officers, but we see on the news, when that does not happen. And we're seeing more and more of an uptick in a necessity for this type of thing to take place. So I appreciate the fact that you are on the wall, trying to do everything that you can do to support this bill. And it is opportunities like this where we can come together and make it very, a broader awareness of what needs to take place to address these issues for those affected with mental illness. Is there anything that you mentioned our community and the uptick of these events? How can we as a community continue to bridge what we need to do in order to bring some collaboration and more awareness to these conditions in our community?
That's a great question. I will say I've seen an evolution in just my, I got out of residency in 2001, so it's now 2023. And I've certainly seen an evolution in just awareness and acceptance that mental illness exists. When I first was in residency, I literally had patients who were seeing me in secret, that they were told that they would be disowned if they, and that, pray it away, you're not strong enough, you should be able to handle this, just pull yourself up from the bootstraps. So luckily, I think that with more, people coming out and acknowledging, yes, I suffer from depression, or I suffer from bipolar disorder or schizophrenia, there's been a little bit more awareness evolving. So one, educating ourselves that mental illness exists, that the brain is an organ just like everything else, just like the liver and the pancreas, and it can get disordered and it needs help and treatment. And then two, not being afraid to talk about if you see a loved one or a family member or someone you care about not doing well. If you start to notice, we could talk, about symptoms to look out for, with depression. Are they not sleeping well, not eating well? Are they kind of getting more disengaged? Are they looking sad and hopeless? Are they starting to talk about things like that life isn't worth living? These are red flags. And, I encourage people not to be afraid to ask the question, like, should I be concerned about you? How are you feeling? Do I need to be worried about your safety? We hear, these suicides of people who people look back and say they would have never thought. And it's unfortunate, but then when people do think, they probably did start to see a little bit of something, maybe, or maybe they didn't. But I tell people, don't be afraid, to have that conversation, and also let your loved one know that you would never be okay. That if they were to take their life, that you would be devastated. Some people think if you have that conversation, it might introduce that thought into someone's head. But some people need to know depression will make people think, oh, you know what? If they would be better off, I might be a burden. They'll eventually get over it. And I tell my patients, no, you let your family members know. I would never get over it. I would be devastated. Would I have to go on? Absolutely. But I would be devastated. And please know that there is help out there, and depression is treatable. Suicides are preventable. So awareness, not being afraid to have the conversation, kind of learning more than just about, it's more than just depression. It's bipolar disorder, it's schizophrenia, it's helping, staying away from substance use, so I would say awareness, acceptance, educating yourself, and then kind of advocacy, kind of getting more involved when you see things aren't right, or you start hearing like things like the AOT bill, see what you can do, call on your congressman, again, my eyes were just open, and I was a little just upset about how I was like, oh, okay, this is over, and let's go to our next thing, where and still had the same issue going on. So advocacy, education, not, being in denial, that mental illness does exist. We've had to educate even our clergy and our faith-based networks to understand that when you're in the pulpit, when someone's in your audience and they might be struggling, and if they hear a message that's making them think that, oh, just pray about it. Of course we want to pray. I'm a woman of faith, and I believe that, yes, prayer works, going to God, but God put people like me on this earth for a reason. And that's the education and the tools to try to help people, and people be mindful that when they're in positions of power, they have some platforms that they need to be educated themselves, and they can say things that are detrimental. So, I'm all about it. I'm glad to see that as time has gone on, there's been more acceptance. I think men, there's more of a movement with men talking more, men being afraid to cry. Men suffer from mental illness just like females do. And that doesn't have to be something that's brushed under the rug, or that you should feel guilty or feel ashamed about, that you're taking stock of your health. You can only be as good for yourself. If you're not good for yourself, you can't be good for your family. So helping people to realize that you are doing the noble thing about making sure that you're healthy, your loved ones are healthy, and we can't, continue to think that mental illness is just a myth, and it's just, it's an illness, and it's reality, which is the thing. And again, from the suicide perspective, just not being afraid to have the conversation and letting people know that they cannot sit by and, we have to take action, and that suicide is real, and it's killing way too many of us. And it doesn't have to be that way.
Yeah. Dr. Lewis, you have removed the stigma. You've removed it. And advocacy is going to be the way, I think, to really raise the awareness and cause people to act more readily than what we've done in the past. I want to say thank you. I really, you have covered all the bases, and now it's time for us to just go out and do what we need to do to try to assist in making sure that our loved ones are being taken care of, and that mental health is no longer something that they have to hide behind, but it is something that is treatable, and that there are services and resources available to them. I want to just say thank you so much. If there's any other parting words that you have, do share, because we want to make sure that we get it out there. Any resources that may be available that you can point folks to. Glad to receive that information as well.
Okay. Well, one, I want to say thank you for having me here. I know you reached out to me when we met on that the assisted outpatient treatment circuit, and I'm available anytime. You know, one of my passions is kind of educating our communities. I will leave you with my email address, and you can put it on your platform. And if anyone wants to reach out to me, they can feel free. Baltimore Crisis Response is an excellent for Baltimore City. It's an excellent source of if you're in crisis and you need someone to talk to and help to how to navigate a situation, they can help. Not if anyone has a family member they're concerned about their safety of others in the setting of a mental illness, they can call 911. They can go to their nearest court to get an emergency petition, but do not hesitate. You call 911, let the police know that there is an emergency, a mental health emergency, and they do try to embed now mental health professionals there. NAMI is a great organization. You know, we've got a lot of good organizations out there. So I can certainly kind of give you some more of the organizations that we work with. But I think the main thing I want people to leave with is that mental illness is real. Mental illness is treatable. Suicide kills. Suicide is preventable. And it's our job really to kind of educate ourselves, to be aware, and to not be afraid to have those conversations with our loved ones and get them the help they need, and then to advocate and hold our legislators accountable. You know, just hold them accountable and tell them, you know, we're sending you places to do a job. And what I've learned is that people don't like controversy. You know, they don't like, but if you're in a position, you have to deal with that controversy and you have to do the right thing. So, you know, we're just looking for partners and advocates, and I'm always available, you know, to try to help, you know, people kind of learn more about this mental health, you know, space that, you know, that I live in daily. And I do feel like I think God said, this is what you're supposed to be doing. And I think the people when we were younger, my sister and I think they got it right. You know, she's an attorney, the psychiatrist, and yeah, she would never probably survive in this space.
I love it. Well, I want to just say thank you so very much. And thank you for being our guest on Promising Unleashed. I hope that you will come back.
Absolutely. Anytime.
Yes, because we're not finished talking. There's more to this issue, and we want to see what happens with that AOT bill. Yeah, so we'll definitely have you back once that is passed. We're speaking in the affirmative that bill will be passed. So thank you so much for joining us, and thank you for being our guest on Promising Me Unleashed.
You're very welcome.